All right. So without further ado, I'm going to go ahead and get started. We're going to start with our executive summary. Before I begin, I wanted to see if Katerina was available to say a few words. Katerina, can you unmute and make an intro?
I am here. Can you hear me?
Yes, we can.
Okay. Hello, I'm Katerina Kiefer. I'm co-director with Ed of our center. I am very glad that you're here, and I apologize for not being with you in person for health-related reasons. But we have a very full and exciting agenda. So as Ed said, without further ado, let's get into it.
Thank you so much, Katerina. So our center is a little over a year old, and what we're going to talk about today in the first session is what we've accomplished in that time. So just to remind everyone, our mission statement is to prevent suicide by accelerating delivery of evidence-based compassionate suicide care. That's what the center is about. And the P50 specifically is designed to study how suicide care technologies can help to support the primary mission. This first year and change, we spent a lot of time building our center infrastructure. So there are two cores in the center. There's an administrative core and a methods core. We staffed those cores and the units within those cores to service CAPES projects and faculty. We deployed our organizational management software. So I'm going to present what we've done, and when you see a double asterisk that's in red, it means that there was a challenge associated with this accomplishment that I want to review briefly. So we're going to talk both about the accomplishments, but also the challenges. Because UMass is a Microsoft shop, we decided that we were going to use Microsoft tools to be able to manage the center. That meant projects, teams, and we had to create our own email service called PowerSend. So the distribution lists that we use are created are from the UMass tech team, and they label that email system PowerSend. So we use these organizational tools. That was a real challenge because it's difficult to make teams work for everyone, especially for our partners who are not part of UMass. So it works really well for UMass related work, but we had challenges, as many of you know, with trying to get teams to work properly with other organizations. And we're slowly working through all of those barriers. We organized and began sharing the CAPES resources. The CAPES resources are really an important part of the value of being part of the center, because you can access a variety of resources that CAPES faculty and the center itself produces. This is primarily going to be shared through Teams and SharePoint. And we have this asterisk here for the reasons I mentioned earlier, that it isn't always easy to be able to share our resources using those software. We worked on building the CAPES Lived Experience Advisory Board. The CAPES Lived Experience Advisory Board has recruited people with their own lived experience of mental health and suicide ideation or suicide attempts. And this advisory board is available for all of the CAPES projects to be able to provide their point of view and to be able to review protocols, to be able to advise in every way, shape, and form of CAPES. So when we make decisions, when we plan projects, when we roll out resources, we're looking at it not only from the scientific lens and the clinician lens, but also the lens of people who have lived experience. We built and deployed a fantastic website, thanks primarily to Laura Kelly. So the website is really awesome. We originally had planned on having the Zero Suicide Institute and Education Development Corporation to build the website, because the Zero Suicide website, I think, is just an absolutely fantastic website, and we wanted the people who built that to be able to build ours. But the problem was we couldn't execute a contract in time because the lawyers involved at the UMass Medical School and on EDC side couldn't agree on the contract. So the entire year went by with the lawyers haggling, and by the time we had it executed, we couldn't actually spend the money. So instead, we pivoted and we built the website internally in probably about 2, maybe 3 months, and I'm really, really happy with how it came out. We supported more than 100 meetings. So we have meetings at project level, at the core level, at the unit level. So more than 100 meetings. We had a 2-day summit last summer. We had 2 retreats this summer, and of course this summit. I want to express my thanks especially for Carolyn Kelly and Gwen Gold and the rest of the administrative team who have really been responsible for making sure that all of the meetings happen and that they're planned really well with strong agendas. All right, we launched our signature project, Jasper. So we integrated Jasper into Epic here, both in the ED and the ASAP module. That's the module of Epic that's used in the emergency department, as well as ClinDoc. So we're still testing, but the ClinDoc application, but it has been integrated. This is a pretty amazing feat when you think about if you've ever worked with electronic health records, if you've ever worked to try to integrate external systems into electronic health records, you realize that this in and of itself is a massive and expensive project. But we were able to do this in record time. The problem was that we were delayed in starting this effort because of the IT infrastructure process. So when you submit a project to be completed by a clinical IT/IS service, they have all their other projects that have to figure out where all this fits in. And so there was a significant delay in starting. But once we started, the integration actually went very smoothly. And we were able to complete the integration and go live earlier this year. We began Part A. So Jasper has 2 components. It has Part A, which is a traditional randomized clinical trial. That's happening here at UMass. And then Part B is the real world study where we do a full clinical integration. And the first site that started was the Ohio State University Medical Center. So we have about 60 participants enrolled in the Part A randomized trial. That's short of where we're supposed to be. The main delay there, besides the delay in integration and going live, was really revolved around trying to figure out the workflow of our clinical medical ED and our psychiatric ED and fitting in our research processes within the clinical workflow to make sure that we were not delaying care, and also so that we could figure out how to best position Jasper in terms of the clinical workflow so that the tools that Jasper provides would be useful to the clinicians who are working in this setting. So all of those resulted in delays, so we're behind enrollment, but we have been focusing on how we might be able to improve this, both by capturing people earlier in their ED visit so that we can engage them before they get to the psychiatric ED, and also adding other sites. So we started here at university, but then we're now expanding to a community ED in Leominster. And we've already began enrollment there, and actually the procedure there has gone much smoother. The real world study at Ohio State University Medical Center, they of course have the same challenges. They have to integrate Epic into Jasper into their system, their Epic system. So that was challenging, just like it was here. It was made more challenging by the fact that the person who was doing the integration there was brand new to the Ohio State medical system. So he not only had to figure out how their system works because he hadn't worked there before, but also, of course, had to integrate Jasper, which he had never done before. So there was a huge learning curve. They are successfully integrated now, and we're going to be doing our first pilots with live patients, with real patients next week. We also launched one of our exploratory projects, the computerized adaptive test for primary care. So you can see all of the tasks that were associated with these specific milestones that were completed. We were able to conduct the semi-structured interviews with 10 key informants of people who worked in systems that had actually integrated and used the CATs. We were able to prepare iCells. iCells is our simulation center where we're able to actually look and carefully study how people interact with the system from a usability perspective. That includes eye tracking technology. So that has been built in iCells, and what's left is to train the standardized patient actors and then to actually complete the evaluations. So we worked with IS for the CAT MH mental health to be integrated into Epic. And we just got the thumbs up from the steering committee and the green light to be able to perform the integration. So that was a big hurdle that slowed us down, but we received the steering committee approval last week. So we're going to be moving forward with the Epic integration. We expect that to happen by January. We also launched another exploratory project called ADAPT. The purpose of ADAPT is for us to be able to build pathways to be able to translate machine learning algorithms that predict suicide risk into healthcare settings. So right now, whenever you develop and validate a machine learning algorithm, it's going to be on a specific database, and it's difficult and slow to translate that to other data from other health systems. Well, we're developing pipelines that help to improve that process so that it can be done in a more systematic, streamlined, and easier way to allow new health systems to incorporate machine learning algorithms into their own workflow. So we've made quite a bit of progress on this, including translating the leading machine learning algorithm that's been developed by the Mental Health Research Network, that's MHARN. We've translated that to our UMass data, studied that process, as well as we're looking at the generalizability and the transferability across primary care and non-primary care settings. We funded 2 pilot projects. One was to build risk prediction models using the OMOP common data model. So the reason why we're doing this is because if we can use the OMOP, which is a common data model that is used throughout the country, we'll be able to study how we can translate different algorithms using this common data model, which will make it easier for us to translate it and to prepare and validate algorithms without having to actually use identified data doing so. So we can do it using OMOP and something else called Odyssey, OHDSI. The second pilot project was optimizing ReachCare. So ReachCare is a software application that was built on the ED-Safe studies. So ED-Safe, there were 2 studies that I was co-PI on, and we established that the intervention that we delivered actually decreased suicide-related behavior after the ED visit. All of the delivery of that content was really very manual and was not automated in any way. So what we did is we figured out how we might be able to use technology to improve the delivery of that intervention, and that's what ReachCare is. So ReachCare is based directly on the ED-Safe studies, and we're further adapting the ReachCare app, both the tablet-based app and the mobile app, for self-administration using some rule-governed chatbots. We were able to support 4 emerging scholars and 2 established scholars. So our established scholars were Nancy Byatt, who is here at the UMass Medical School, and Linda Isbell, who's at UMass Amherst. And then we had 4 emerging scholars: Laura Kelly, Ariel Graham, Dominic Denning, and Martha Zimmerman. We also did something that we hadn't actually submitted as part of the grant, but this was an outgrowth of the work that we were doing across the P50s. So there are 7 P50s that are funded by the NIMH, and what we recognized whenever I visited the Inspire P50, which is at the University of Pennsylvania, that we're doing a lot of the same work. So you can see this giant overlap where we're doing a lot of the same work, but we also have some unique stuff in each of the centers. And the center directors there, Maria Akendo and Greg Brown, and Katerina and I got together and thought that what would be a useful experience is if we could exchange faculty between the 2 centers, so we could create a faculty exchange program. That way we would be able to send a faculty member there. They would learn and do an immersion experience, maybe more than one immersion experience, to really understand what's happening at that center, and then vice versa. They would share faculty here so that faculty could benefit. And then those faculty, of course, that we're sharing would continue to be work on collaborations and identify whether we have common opportunities to submit common grants and also to share our resources so that we don't have to reinvent the wheel. So this was a idea that we had. We formalized it. We created all of the infrastructure around it, made sure we understood who was going to fund what, and then we selected our first exchange faculty member, which is going to be Fifan Liu. Fifan works in PQHS, Population and Quantitative Health Sciences. He is a data scientist. He really focuses on machine learning and artificial intelligence applications. And so he's going to be our faculty who's going to work with the Inspire Center, and the Inspire Center is currently identifying what faculty or even a staff member that they're going to send to UMass. I want to talk briefly about our publications. So when you look at a center, one of the most important ways to evaluate the impact of a center is to look at the scientific publications that are coming out of the center. So we collated all of the publications that were published after the beginning of the center, so April 5th of last year, and we found that our faculty had published 155 publications that are directly related to the CAPES mission. So these are not all the publications from all the faculty. These are publications that are directly related to the CAPES Suicide Prevention, Implementation Science, and Digital Health mission. You can see that the citation counts was around 247. That's 1.6 citations per publication. And maybe the best overall indicator of impact is the field-weighted citation impact. With the average field-weighted citation impact, if our citations were the same as the comparator group or of similar kinds of studies, it would be a 1. So 1.26 means that we actually are hitting above the belt. We're really having a greater impact through the measurement of citations than the average comparator group. And that's important to consider, both because it shows that we're having a scientific impact, but also that we have a small window that we've actually looked at this. So usually this field-weighted citation impact doesn't stabilize until after around 3 or 4 years of monitoring publications that are coming out, because it takes a while for the science to be cited. So to have a 1.26 rating this soon into the center is actually quite an accomplishment. This is an example. This is just the publication by field. So you can see the majority are in medicine, but we have quite a bit of neuroscience, nursing, psychology, and social sciences as well. This is a sampling of some of the high impact papers published in JAMA and other high impact factors, impact journals. And thanks to Kate, by the way, for preparing all of this summary of our impact. This is our word cloud of our published papers. You can see suicidal ideation is the term that's most commonly cited or referenced, and then there's suicide risk, and then you can see a whole cloud of a lot of other topics, which really represents the diversity of the types of work that we're doing. We've also built a CAPES library service. So CAPES has its own page on the UMass repository now. So you can follow this link to find the repository. It'll be the centralized area where all CAPES products, tracking metrics, publications, newsletters, et cetera, that are going to be public facing. This is where they're going to live. So it makes it really easy to access these public facing resources. We submitted 38 grants. We stopped counting it in December for this report. So we submitted 38 grants, mostly to NIH. We landed a 12-month planning grant from a major philanthropic funder, the Four Pines Fund. So this is going to allow us to be able to help to shape the future of what the Four Pines Fund actually funds. So they funded us to be able to digest the emergency crisis landscape and figure out where the biggest gaps are that would be the most important to fund in order to be able to elevate the quality of care provided across the entire emergency and crisis care landscape. So that's what we're going to be doing the next 12 months. And then they're going to use those recommendations along with the recommendations from other planning grants to be able to decide on what their funding priorities are. And then they're going to fund those areas that seem to have the greatest impact in the field. Presentations, we had 63 presentations at regional, national, and international conferences. What are our opportunities to pursue in years 2 through 5? We really need to master our organizational communication and sharing tools. We've kind of done a good job, but I think we can move to do a great job to make the administration more efficient and also to provide more value to people who are affiliated with CAPES so they can more easily find resources and get connected to the faculty who might be able to help them with their projects. We're going to sponsor networking events to further develop synergy. So right now, we still have lots of siloization. We have people working in their own domains on their own projects. That's difficult to break, especially when we don't have a lot of opportunity to be together in person. So we are going to be working actively to try to sponsor networking events to be able to get people to know one another so that they can collaborate more synergistically. We plan on expanding training opportunities. We're going to pursue a 3-center collaboration. So there's a center at Brown associated with Butler Hospital. There's a center at Harvard. So we have 3 centers within a very close geographic range. And all of us have sponsored symposium and summits or conferences this month during Suicide Prevention Awareness Month. So I was at the Brown Center earlier this week on Monday, and we were talking about how it might be great if we pulled our resources and had a regional conference. That way we could probably do a bigger and better job and then only do it once for all the 3 centers rather than having 3 separate, potentially conflicting experiences. Integration and harmonization with work at UMass Chan and UMass Memorial, the affiliated institutions and unaffiliated agencies. So trying to really focus on how we might be able to provide better services and more collaboration with all of our partners, expand the CAPES reach through social media and through promoting our website, and getting started on commercialization, intellectual property, and philanthropic opportunities early. We have already started on the philanthropic opportunities. I really think that the Four Pines Fund collaboration is going to be a huge benefit for us in the long run. And we're working closely with the Bridge, which is the organization here within the UMass Chan Medical School that really focuses on intellectual property and commercialization of that intellectual property. All right. I'm going to hand it over to Laura Kelk now.
Hi, friends. Thank you all for being here. I'm going to introduce myself quickly. So I'm an assistant professor here in psychiatry and emergency medicine. I'm also a person with familial lived experience. And what that means is that I have friends or family or friends and family who have direct lived experience themselves with using acute care services related to suicidal thoughts and behaviors. And I share that with you because of the participatory action research and community engaged research that we're doing. So we are not treating the participants in our studies as subjects. They're not. They're partnering alongside us. They're helping us learn and make things better. And so just wanted to share that with you all first. I'm also going to invite you next to take out your phones if you are in person, and if you are online, just click this link at the top here. And you're going to come to our website. I'm so excited about our website. Really thrilled. In part because we were struggling and Ed specifically asked me for help. And I was able to basically make a connection with our graphic designer within iSpark. It's our Implementation Science and Practice Advances Research Center here within UMass. We're housed within the Department of Psychiatry, but we have just a lot of amazing skills in terms of like communications, marketing, graphic design. So I'm going to have us scroll down. There's one thing I want to point out first. It's the 988 Suicide and Crisis Lifeline. You can click on it here. Well, you're not going to see it. You'll see it if you click on the 988 icon that's all the way at the bottom of the website. So you can only see the slides. Is that right? Okay, that's fine. So on your phones or online, you are looking at our website. If you scroll all the way down to the bottom, you'll see our 4 social media sites. I would recommend going on the LinkedIn one. It says LI. It looks like this. You'll see posts like this, but you might, if you are not already logged into LinkedIn, you might see some directions to log in. If you don't have a username and account set up, you'll be recommended to do that. If you're on your phone and you have the app on your phone, you're seeing basically probably this summit post or a picture of a beautiful mountain graphic that looks kind of like this. Okay. So I'm going to go back to the slide here. If you are already lost, it's okay. All you have to do is, again, like click on that top link. If you're here in person, you can click on this QR code. I'm just going to go over a high-level overview of the major sections and give you a little bit of a metaphor about CAPES and our dissemination tools and why we're asking you to go to our website or like things or comment on things on social media. So since I'm here, why don't we go to the mountain? I like rock climbing. I also enjoy hiking and walking around the woods because I'm a millennial and we struggle a lot with being online and our mental health probably and wellness. So we escape into the woods a lot. So we are all in this work climbing, advancing science together. We're working up this mountain. If we're in year 2 of 5, we're getting there. We're 2 years. We're not at this summit yet, metaphorically. We're just here at the summit today, being together and learning about this great work. We're also being brave. So I am really afraid of heights. When I first started dating my husband, we would go to an indoor rock climbing gym. It ends up being a lot easier to get to the top of something that's really tall when you're hooked into a harness and you have someone you trust at the bottom. It's also a lot easier when you have people around you showing you how to do this difficult work and like lifting you up and cheerleading and collaborating. So when you're in an indoor rock climbing gym, everyone's like working the problem together. There's bouldering where you don't have those ropes to keep you making you feel safe. You just watch other people kind of get up those tricky routes and you learn how to do it too. And this rock climbing gym that we used to go to, they tried really hard to implement some technology things. I think we could probably all feel their pain that it can be difficult to implement something with technology that can get a little bit glitchy. But what it did was it allowed the people at the front desk to not need to spend so much time checking people in, and instead they could spend the time, helping us make sure we're safe, get in our harness properly, answer actual questions about rock climbing. And they had a wellness and yoga section. So there's that too. All right, so I need to spend 2 seconds to figure out how to show you all the actual website. I'm going to click through some things to show you how to do this. This is our beautiful website. So I'm going to walk through some things relatively quickly. I know you all can click on things on a website. Everyone here is very smart and capable, but sometimes we have some, say, time pressure or burdens on our executive functioning. It can be helpful to look through the things together. So if you want to see CAPES in the news, like you want to see our NIH reporter description, any of our quarterly newsletters, you said wasn't CAPES in the Worcester Business Journal, you wanted to check that out, you just click on those links. If you wanted to know more about CAPES, click here. You can learn more about the Zero Suicide Framework, for example. If you wanted to know more about the admin core and all of us here, if you want to email Dr. Nebaker and request an LC unit, oh, no, you can't. Not right now. If you wanted to email Dr. Nebaker and ask for an LC unit, like consultation, for example, there is a REDCap form, but if you wanted to email her directly, for example, if you needed to know more about machine learning or any of our other methods cores, that information is here. And then if you also wanted to learn more about the faculty within each of our cores, so our core faculty, any of the unit leads or project leads, we're all listed here. Come down. And we'll have to update Dr. Lemon's description with her new endowed chair appointment. And if we go into projects, say you wanted to learn more about Jasper or any of our exploratory projects like Lemurs, Adapt, CATS. If you wanted to learn more about our 2 pilot projects, this is just what is up here. The pilot projects are ongoing, so that will be updated as well. If you wanted to read about any of the other projects by CAPES faculty, those are there. Our beautiful impact report. Thank you to the evaluation unit. But you can click on our impact report and see that here. So this was shared out at the retreats in July. So folks may have already seen this, but it's there for your viewing pleasure. Our partners page, this is more new, but this will be expanded. So these are some of our partners. If you are a person who needs some help or support for yourself, I want to just point out mostly these like growth and wellness supports and the personal stories. Most of these websites and resources were shared by our Lived Experience Advisory Board. I'm a clinical psychologist by training. I should know about these resources, but there are so many of them, and I can't necessarily speak to if they are good or not, if they're helpful or effective. But our advisory board specifically can. They have that lived expertise. And so these are a real value added to our website and to the field based on their experiences and support. There are some additional resources if you're looking for help for somebody else. There are digital tech and resources, so some suicide care tech, publicly available apps. There are certainly many other freely available apps. Most of the apps in the App Store that are for suicide prevention are free, but we have these on our website because they're funded federally. We know they have some good data to them too. We have some more publications related to digital health and tech. We have our clinicians page. If you're a clinician or a dual doc, meaning that you do both research and clinical work, and you want to know more about some suicide risk screeners or self-report measures or other best practices or suicide prevention within specific settings like acute care or primary care, all these resources are here for you. And then for researchers, we have a tip sheet that was also available printing, the print-based version when you first walked in. We also have all of the journal articles that are for free in PubMed. There's a link here, so if you wanted to see Celine Larkin's sole first author recent publication about implementation of suicide prevention activities in acute care, you can click on that. If you wanted to see more about suicide epidemiology, some papers that I've co-authored with some colleagues, you could do that too. So here's what I think at least is helpful for me. So I forget what I ate for breakfast. And so I think, what was the name of that thing that we talked about in that meeting? I think it's called CATS, but I can't remember if there's a kid version. Oh my gosh, wonderful. Here it is. And how much is it? And could I use this in some type of grant application that I'm submitting, not tomorrow, but maybe soon? Well, I'm going to click on LinkedIn then. So this is what you all are going to see when you have, when you aren't yet logged in. But we're just going to look at the, I'm going to press follow, and you'll be directed to log in here. I'm going to go into Instagram next. Instagram's not going to give us a preview either, so you also have to log in. And then click on Facebook. Have to log in. You get a little sneak peek though in Facebook. Look at how beautiful. So I just need to say thank you to our dance unit staff members specifically. So the dissemination and community engagement unit, it's essentially made of myself, Bashir, Gwen, Nancy, and Jonathan LaRue. And I would not be able to create these things without them. They know how to do these beautiful posts in Canva, how to, I don't know, do all sorts of things to tag people or make connections basically on social media. We also had a really talented undergraduate student this summer, Arba Camberry. So she's another person who I think we're indebted to in the center for making everything look really pretty and also really accessible. And the last is Twitter X. Twitter X, I think, will make us, oh, yeah, no, it'll make us log in, but we might be able to see. No, we can't see a preview anymore. So what I would encourage you to do, if you do not have any of these social media, but you want to engage with CAPES on social media, because we are within UMass, or if you're within academia, I would recommend starting with LinkedIn. It's very professional. There's some humble bragging, which sometimes can be, it's a thing. I don't love it all the time. But if you spend about 10 minutes on LinkedIn a week, like and engage with our posts, I think it's helpful in terms of seeing like other people to network within the field, and then also see all our dissemination tools that we're sharing out and just information about the center. All right, well, thank you for your attention. We can take questions, I think, now. Okay.
Yes, if you want to ask a question, come up to the microphones, please. Is there anything on the Q&A, Nancy? All right, great. Thank you so much, Laura. That was awesome. So I'm just going to encourage you to engage in some way with CAPES, even if it's just the website. And if you're thinking, okay, what is CAPES about? What are the resources that are available? Think first the website, and then social media. It'll be the easiest way to actually access more about CAPES. And then the next tier is going to be our resources that we share through Teams.